Hi, this is Brian Kim. I want to share with you this case of a patient who has a hypermature cataract, severe zonulopathy, anterior capsule fibrosis, and retinitis pigmentosa. This patient could not have standard phaco. I really felt like it was impossible for this case, and you'll see what I mean when I get started, because when I start the Rexus, it is literally impossible to continue it. And so I'm employing manual small incision cataract surgery. I am not an expert at this technique, but through the thankful mentoring from Dr. Glenn Smalley at Dublin Eye Center in Dublin, Georgia, and his team, when I went on a mission trip with them to Jamaica, they taught me the basic skills of MSICS, and I'm going to show you how I perform MSICS on this very dense cataract with severe zonular disease. So I go ahead and mark the central cornea in typical fashion. I make my paracentesis incision first on the right side and then the left side. At this point, I'm still thinking phaco the entire way. I inject some intracameral epinephrine and then some intracameral air, as well as some trypan blue. You can see the anterior capsule fibrosis. And what that means is when you have that fibrosis, it means it causes capsule contraction in that area. And when you have capsule contraction, you can see the radial lines of stria in the peripheral anterior capsule. And that means that there's significant zonular disease. It means that anterior capsule in the periphery is giving way to that central fibrosis, and it's been pulled centrally, which again shows that there's severe zonulopathy. So I'm pushing some viscoelastic in, and then now this is with a sharp tip capsulorhexis forceps. I puncture through the capsule around the area of fibrosis in the periphery. But as I'm grabbing the anterior capsule material, you can see the entire lens is moving. There's significant stria. And as I'm pulling, there's just no counterforce. The zonules are not able to provide that counterforce as I'm trying to do this. I put a Lester hook in to see if I can pull on the anterior capsule as I pull on the Rexus, and then I decide, you know what, this makes no sense. If I do that, it's just going to cause more ripping of the zonules. This is a can opener capsulotomy technique, something that I learned in my residency when I did my very first extracapsular cataract surgery at LSU. And you basically go around like a can opener, creating tiny little puncture marks with the cystotome needle, and you're just trying to puncture all the way across. I'm going to make the Rexus a little bit on the larger side since I'm going to be prolapsing the entire lens up. You're essentially placing a bunch of small punctures where you want the capsulotomy to be. And then just like the little perforations on a stamp, you should be able to create a capsulotomy. All those little puncture marks also create micro weak points. So as you prolapse the entire nucleus up, you're not going to have posterior radialization forces to cause the lens to go south. This is an area that just wouldn't puncture, and so I'm using microforceps as well as micro scissors to cut that anterior capsule fibrosis off. Yep, it's really stubborn, thick fibrotic material. You see it's so white. And I'm just trying to make sure it's completely off the capsulotomy before I take it out. And here it is. So I go ahead and close that phaco incision. I don't want to make a giant corneal incision that's going to induce so much astigmatism. And so I'm going to close that incision with a 10-0 nylon suture. And then this is my peritomy going to start the conjunctival takedown. And again, as I'm doing this, I'm thinking about Jamaica again, thinking about Dr. Smalley and his team, and for the skills they taught me while I was in Jamaica. And it was a great experience, and I do think anyone who wants to do really complex surgery, and when you can't do phaco, you have to have other options. And so this is an excellent technique to be able to get that lens out. So as I do the peritomy, I start to do cautery. Cautery is so important with this. If you don't have cautery, you don't have a clear view. If you don't have a clear view, you really can't do this surgery. And so I did cautery. I'm holding the eye with 1-2 forceps, and you want to make a frown incision on the sclera. You want to be far back enough away from the limbus so that when you make your incision, in order to reduce any induction of corneal astigmatism, and because I don't do MSICS a lot, I'm not planning on making this a self-sealing incision with no sutures. I'm already planning on having to put sutures in. The hardest part of this surgery is the depth of your blade when you're making your scleral tunnel. And so I already feel like maybe I'm a little bit too shallow. But at the same time, if I went too deep, which I think is worse, if you go too deep, you'll have premature entry into the anterior chamber. And since you're so far posterior to the limbus, you're going to have iris prolapse. And so iris prolapse is just awful in this setting. Again, if I was trying to do a self-sealing surgery, you would have to go deeper. When you do the scleral tunnel and you're rather thin, it's going to be harder to close this. And so, as you can see, I'm a little bit thin, but that's fine. I'm going to make sure I keep going around, trying to stay within that plane. You saw I was trying to go up there. And that's, again, part of the technique, the nuance of rotating your wrist, making sure your blade stays within the same plane. You don't want to come higher or lower as you're extending the tunnel. And I'm trying to do the best I can to stay within my same plane. And it's really just a wiggle maneuver. I think using a brand new crescent blade is important. If you have a blunt crescent blade, it's really hard to do this, especially when you don't do this a lot. So I do recommend making sure you get a brand new crescent blade when you do this maneuver. Now that I've made my tunnel, I go ahead and enter with the sharp keratome blade, and then I'm extending the incision here. And again, please don't look at this case as an example of a perfectly executed MSICS. It's not. Again, my scleral roof is really thin here, and I'm doing the best I can to widen the incision here. But, when you're in the United States and you have a patient like this, retinitis pigmentosa, no zonules basically, you have to have other ways to take this lens out. So I use my hydrodissection cannula to loosen the lens up. You can see it's already tilted. It wants to come out. I'm pushing some viscoelastic underneath the lens to separate the lens from the capsular bag. You can see it's already tilting up. I'm just trying to tease it up into the anterior chamber with the cannula. Part of that technique is pushing viscoelastic, but also rotating it by rotating the lens, just like when you're rotating the lens after hydrodissection for phaco, you want to completely disassociate the lens from the capsular bag. So after making sure it's completely loose, I go in with the lens loop, get underneath the lens, making sure I'm horizontal, lift the roof of the incision with forceps, push down a little bit as the lens loop comes out, and the lens comes out pretty nicely. You can see that is an absolute rock of a cataract. It's really, really dense. And I'm glad I did not try to phaco that thing. I would have just killed a lot of endothelial cells unnecessarily. And so I go ahead and close the incision with a tendon-nylon suture. You can see I'm doing this at 8x speed and just closing the main incision. No reason not to. I've spent all this time getting the lens out. And you want it completely sealed. No reason for any iris prolapse. Luckily, you saw with this case, I had no iris prolapse. I did not have any vitreous present as I delivered the lens. You can see that golden nugget of lens there. Again, this patient, again, if it was just a phaco, if it was going to be that dense cataract in the presence of good zonules, I would have tried to phaco it, and I probably could have. But when you have no zonules, it's really a non-starter. It's really hard to proceed with the surgery when you have no zonules. And you see, as I'm hydrating, you can see the bag is completely flopping around. There's absolutely no support for the capsular bag as I'm pushing BSS to inflate the eye. Really, really difficult situation here. There's a little bit of a nugget there. I'm going to try to get it out. And then I eventually do here. So again, you can see the bag is completely unstable, essentially no zonules. I would have certainly lost lens material into the vitreous space if I tried to phaco it. With high infusion pressure, that bag would have just been shot posteriorly. I doubt it would have been stable there. So then this is atovical. I'm just closing the conjunctiva now. So again, this patient I left aphakic on purpose. The visual potential was rather low anyways in this patient. And we are going to try to fight another day, live for another day, and reevaluate her in the office and determine if a secondary lens is necessary for her. But again, this case is to illustrate that when you have a rock-hard cataract and you have anterior capsule fibrosis with peripheral radial stria folds in the anterior capsule, that is a sign that there is severe zonulopathy, because as the anterior capsule, that central anterior capsule fibrosis contracts, it causes that peripheral radial stria being pulled, the capsule, peripheral capsule being pulled centrally. And why would that happen if the zonules were good? And that's an indication that the zonules are not good. And so you saw that I tried to do the typical rhexis, didn't work. So we did a can opener capsulotomy. I had to use scissors in order to cut the fibrotic material. And then hydrodissection was rather easy. The lens popped up, push viscoelastic underneath the lens to push the posterior capsule back. And then you want to rotate that lens and carousel it out into the anterior chamber, use the lens loop to get under the lens, and you want to stay fairly horizontal. You don't want to point the lens loop down toward the vitreous space. You might catch the posterior capsule, and as you pull the lens up, you're going to bring the posterior capsule with you. Trust me, I've seen that and I've done that, and that's not the way to do it. You want to stay fairly flat. Get underneath that lens like you're sliding one of those wood boards underneath a pizza in the oven. You want to stay flat. Slide it underneath, and then if you have an irrigating victus, you can push infusion on, lift the roof of the incision. You want to push down against the posterior lip of the incision, and that causes an incisional gape, and you can slide the lens out. So this is my attempt on performing manual small incision cataract surgery, again, as a phacosurgeon who doesn't do a lot of these. Again, having the fundamental skills based upon my past experience on mission trips, doing dozens of rock cataracts under the supervision of mentors, gave me tremendous experience, also the confidence to be able to tackle these cases. And again, even though the case wasn't executed flawlessly, it was obviously executed well enough to be able to finish the case and provide a safe and good outcome for this patient. So I hope this was helpful to you, and I thank you for your attention.